I like to look at their jaw, first of all, just to see where the bite is. If they're in a class 3 relationship, you know, the bottom jaw is so forward like that, you can't even start edge to edge because you're way beyond it. So a class 3 patient, which doesn't tend to resolve issues too well, they're difficult. I tell people that it probably won't work, but we'll try. Usually I start them right where they are, and I don't go out any further with them from the beginning. If they're a class 1 occlusion, I almost always start them at edge to edge. And that's a great position to start with. If they're a class 2 and they're already behind, 4 to 6 millimeters, you might bring them forward just 2 to 4 millimeters, but not all the way to edge. So you have to look at the jaw just a little bit to make sure you know where you're going with that. I don't like to do vertical, because if you're raising a person up vertically, the biggest problem you can run into is losing the primary lip seal, which means, like, if I'm right now, my lips are closed. That's how you normally you'll sleep. Lips closed, that means you breathe through your nose. If your lips are open, like this, it's gonna make you breathe out your mouth. You're not gonna breathe out your nose. So the alternative you'd have to be is putting tape to try to tape your lip down just to keep that mouth shut, and so raising the vertical doesn't always work best. Most of your appliances, if they're an acrylic appliance, you're talking a 4 to 6 millimeter thickness of your appliance already. So if you have 4 to 6 millimeter thickness of an appliance, you don't want to go any beyond that, because then you lose that primary lip seal. So, but I routinely do use lip taping, and the kind I like, you can buy it on Amazon or eBay, and they just look like a shape of a lip, and you just put it right over the lips here. It works really, really good.